Welcome to the Spinal Chat Podcast, powered by the Pennsylvania Chiropractic Association, where science meets purpose. This is our Deep Dive Series, where we examine important research and healthcare policy issues and explore what they mean for patients, providers, and the future of conservative care. Today, we ask a difficult question. What happens when widely used spinal procedures for chronic pain show little additional benefit over sham treatment? We examine the 2025 BMJ evidence, the roughly $9 billion spent annually on epidural injections in the United States, the debate surrounding the findings, and what it could mean for the future of chronic spine care. This discussion focuses specifically on chronic non-cancer spine pain and does not address acute injuries, red flag conditions, or individual treatment decisions. The question at the center of today's deep dive is simple. When the evidence changes, should the way we deliver and pay for care change with it? Let's dive in.
So what if one of the most sophisticated, widely used procedures for chronic spine pain, what if it provides little more average benefit than a literal sham?
I mean, it's a wild thought, right? But right now, this massive emerging stack of data is suggesting exactly that.
Yeah, including this blockbuster 2025 review in the British Medical Journal, or BMJ, it's really shaking things up.
Oh, absolutely. We are basically looking at a situation that's putting a $9 billion industry on a direct collision course with reality.
Which is why we're doing this deep dive today. Our mission is to really unpack this evidence around routine interventional procedures, like epidurals, and see what it means for you, the listener.
Right. But before we get into the collision itself, we really need to draw a firm line in the sand regarding the scope of this data.
Yeah, that's super important. Let's clarify what we are and are not talking about.
Exactly. So this discussion is strictly focused on chronic, non-cancer spine pain, meaning pain that has persisted for more than 3 months.
Okay, 3 months or more.
Right. And that includes both axial pain, so pain localized right there in the neck or the back, and radicular pain, which is the kind that, shoots down an arm or a leg.
So we are putting a clear fence around every day, persistent back and neck pain.
Yes, exactly.
Meaning we're definitively not talking about acute medical emergencies.
No, absolutely not.
Like if someone has acute severe sciatica where they're actually losing motor function or red flag conditions.
Right, things like a spinal fracture, an active infection.
Or an inflammatory disease.
Yeah, or cancer-related pain. Those are entirely different clinical universes.
Yeah, so if you're dealing with that, this doesn't apply to you.
That distinction is non-negotiable. In those acute or disease-specific scenarios, interventional procedures and injections play a really vital, often urgent role.
But that's not the controversy today.
No, the controversy we're unpacking centers purely on the chronic, daily, grinding spine pain that millions of people live with.
And whether routine use of interventional needles for that specific population is actually supported by the evidence.
Which brings us to the data causing this whole seismic shift.
The 2025 BMJ Systematic Review and Network Meta-Analysis by Wang and colleagues.
Yeah.
I was, looking through the methodology, and the sheer scale of this thing is just daunting.
It really is. And the rigorous volume of data is what makes it so difficult to ignore. I mean, they started by screening thousands of papers.
Thousands?
Yeah, to find 132 eligible studies. And for the quantitative analysis, like the hard math, they included 81 randomized controlled trials.
Wow.
That encompasses 7,977 individual patients.
That is a massive pool of people.
It is. And they evaluated a whole spectrum of procedures that pain clinics do every single day. Epidural injections using local anesthetic or steroids, joint-targeted injections, radiofrequency ablation.
Intramuscular injections, all of it.
Yeah, exactly.
So let's translate a piece of that terminology for a second, because you said network meta-analysis.
Uh-huh.
What are we actually looking at there? Because that sounds like more than just, a standard review of the literature.
Yeah. Oh, it is. A network meta-analysis is essentially like a massive statistical tournament.
Okay, a tournament.
Yeah, so instead of just looking at trial A, where an injection was compared to a placebo, and then trial B, where a different injection was compared to physical therapy.
I kind of mash them all together.
Exactly. This methodology allows researchers to cross-compare all of these treatments against each other across the entire network of data.
Oh, I see.
It pits all the different procedures, placebos, and therapies against each other to see which ones actually rise to the top for genuine efficacy.
Okay, so out of almost 8,000 patients in this tournament, analyzing all these different needles and procedures going into the spine,
Yeah.
what did the math actually reveal?
Well, for chronic axial spine pain, the data showed that epidural injections and joint-targeted injections probably provide little to no clinically meaningful difference in pain relief.
Wait,
Yeah,
little to no difference when compared directly to what?
when compared directly to sham procedures.
I just want to make sure I'm hearing that correctly. Little to no difference compared to a sham, like a fake procedure.
Yes. To put a precise number on it, when they looked at epidural injections of local anesthetic, the weighted mean difference in pain relief was 0.28 centimeters on a 10-centimeter visual analog scale.
Wait, 0.28.
Yes.
So on a standard scale of 1 to 10, this highly technical medical injection gave about 1/4 of a point more relief than a fake procedure.
That is exactly what the data shows.
I mean, that is mathematically measurable, I guess, but practically invisible. Someone is not going to notice a 1/4 point difference when they're, like, trying to tie their shoes in the morning.
Exactly. The clinical relevance is virtually zero.
Wow.
And they found similarly disappointing results for chronic radicular pain, too.
Yeah.
Even for that shooting nerve pain down the leg, there was minimal to no long-term benefit over shams.
So it's not just the localized back pain, it's the nerve pain, too.
Right. The data was so overwhelming that a companion clinical practice guideline was actually published by Buss and colleagues in the same journal.
Oh, they dropped a new guideline right alongside it.
They did, and that guideline issued strong recommendations explicitly against the routine use of these injections for chronic spine pain.
Okay, so there is an obvious disconnect here that we really need to bridge.
Let's do it.
When I hear sham procedure, my mind goes to, like, the theater of medicine.
Right, the whole performance.
Yeah, I think of the patient being ushered into a sterile room, getting prepped with that cold iodine on their back.
Hearing the hum of the fluoroscopy machine.
Exactly.
Ugh.
Which is basically a live X-ray guiding the needle.
Mhm.
And they feel a superficial prick, but they don't actually get the active steroid baiting the nerve.
That is a very accurate picture of a well-designed sham trial. The patient experiences the entire ritual of the intervention, just minus the actual pharmacological agent.
Okay, so if a patient goes through that theater and they actually feel better, some people might ask, why do we even care if the medicine did the heavy lifting?
That's a fair question.
It's kind of like pressing a broken crosswalk button.
Yeah.
You press it, it doesn't actually change the lights any faster, but you feel better because you did something.
That's a great analogy.
So if someone feels relief, isn't that what counts? Like, isn't that just their brain releasing its own chemicals because they expect to be healed?
Well, yes, expectation is a really powerful biological mechanism. When you believe a highly trained specialist is delivering a potent treatment, your central nervous system actually responds.
By doing what?
By releasing endogenous opioids.
Yeah.
Basically, your body's own built-in painkillers.
Oh, wow. So it's a tangible neurochemical event, not just positive thinking.
Exactly. And furthermore, there's the treatment context, which we often call the white coat effect.
Right, just being in the doctor's office.
Yeah, being listened to, validated, and cared for in this high-tech environment, it significantly lowers a patient's systemic anxiety. And because pain is an output of the brain, lowering anxiety inherently lowers the volume of the pain perception.
Okay, that makes sense. We are calming the nervous system through the environment itself. But, I mean, there is also a statistical illusion happening here too, isn't there?
What do you mean?
Well, people don't generally volunteer for a clinical trial or book a specialist appointment on a day their back feels okay.
Ah, wrong.
They go when they are in absolute agony.
Yes, and that brings in the concept of regression to the mean, which is vital to understand when we're analyzing chronic pain.
Because it fluctuates.
Exactly. Chronic pain naturally waxes and wanes. It is cyclical. Because patients seek intervention at the absolute peak of their flare-up, their pain was statistically highly likely to subside a bit over the following weeks anyway.
Just simply because it couldn't get any worse.
Right. So the timeline tricks us.
They get the injection at the peak of their misery. The pain naturally regresses to its baseline average a few weeks later. And the syringe gets all the glory.
Precisely. The timeline creates this very convincing illusion of cause and effect. And this is exactly why sham-controlled trials are the absolute bedrock of medical evidence.
To filter out that illusion.
Yes. So when the BMJ study shows the active injection is barely beating the sham, it is crucial to understand that this does not imply a patient's pain is fake.
Right. They are genuinely hurting.
And it also doesn't imply their subsequent relief is imaginary. Their improvement is entirely real.
It's just not because of the steroid.
Exactly. What the data reveals is that the physical act of the steroid or anesthetic acting on the nerve is not the primary mechanism driving that relief. The relief is being driven by expectation, context, and that natural healing timeline.
Okay, but, telling a whole field of specialists that their primary tool is essentially a theatrical placebo is not going to go over quietly.
No, it certainly hasn't.
Medical consensus doesn't shift without massive friction. The specialists who perform these procedures every day must be pushing back hard against this interpretation, right?
Oh, the backlash from the interventional pain community has been both swift and highly organized.
Really? What did they say?
Well, several groups of interventional pain specialists published immediate critiques of the BMJ guidelines. Some went as far as to title their critiques with terms like narrative opinion.
Narrative opinion. That sounds like a pretty intentional downgrade.
It was. They were effectively attempting to downgrade the perceived authority of the BMJ's clinical practice guidelines.
So they are fundamentally rejecting the conclusions. But if the BMJ is bringing, 8,000 patients worth of data to the table, what is this specialist's core counterargument?
Their primary methodological critique is that by aggregating thousands of patients into these massive statistical averages, the BMJ ends up underweighting real-world individualized clinical experience.
Okay, so losing the individual in the crowd.
Right. They argue that inside the clinic, there are very specific subgroups of patients who do exhibit strong responses.
Like who?
They point specifically to patients with severe acute on chronic radicular pain. They argue that these specific individuals can experience highly meaningful short-term relief from an epidural steroid injection.
Even if the broad average of all patients shows no long-term benefit.
Exactly.
So are the specialists saying this is kind of like judging a life jacket by testing it in a swimming pool instead of a hurricane?
I like that.
Like by looking at broad averages of everyday moderate back pain, the researchers just diluted the data of the few specific patients in blinding agony who actually get a vital window of relief.
That analogy perfectly captures their concern. They worry that issuing a blanket, strong recommendation against these procedures will lead insurance companies to restrict access.
Oh, which would harm that specific hurricane patient who might truly need a short-term intervention just to cope.
Exactly. We are looking at a classic tension in evidence-based medicine right now.
The numbers versus the clinic.
Right. On one side, methodologists rely on broad statistical averages that show minimal long-term benefit compared to shams. And on the other side, clinicians rely on their daily empirical experience of seeing individual patients report significant, albeit sometimes temporary, relief.
And you, as a listener, really need to understand that both of these perspectives are currently warring over the future of pain management.
Very much so.
But this fierce defense from specialists isn't just about clinical pride, though, is it?
No, it's not.
It's about how modern medicine is built and how it's funded. Which brings us to the $9 billion question.
Yes, the economics.
If the average benefit across thousands of patients is so statistically fragile, why are millions of these procedures still being performed every single year? We wouldn't spend that kind of money by accident.
The economics are staggering. In an editorial accompanying the BMJ studies, Dr. Jane Ballantyne highlighted the sheer scale of this industry.
What are the numbers?
In the United States alone, estimates suggest there are approximately 9 million epidural injections performed annually.
9 million. Wow.
And at an average cost of roughly $1,000 per procedure, we're looking at a $9 billion yearly expenditure purely on epidurals.
$9 billion.
And that doesn't even account for the myriad of other spinal interventions, like ablations or facet joint blocks.
That just feels like an old, deeply entrenched habit that modern medicine just can't shake. How did injections become the absolute default for chronic back pain in the first place?
To trace the origins of that, we actually have to look back to the mid-20th century and the evolution of anesthesiology.
Okay.
Following the Second World War, anesthesiologists became incredibly adept at managing acute pain.
Like surgical pain.
Exactly. They pioneered brilliant, highly effective procedural techniques, things like spinal blocks for major surgery or epidurals for childbirth. These interventions were revolutionary for shutting down acute pain signals.
So they had this incredibly powerful hammer, and they started looking for more nails.
Essentially, yes.
They just assumed that chronic pain was just acute pain that had outstayed its welcome.
And that was the fundamental historical misstep. The medical community extrapolated those acute care successes directly into chronic pain syndromes.
But they're not the same thing.
Not at all. Modern neuroscience has shown us that chronic pain is a fundamentally different biological mechanism.
How so?
Well, acute pain is like a useful fire alarm telling you that tissue is currently being damaged. But chronic pain often involves nervous system sensitization.
So the alarm is broken.
Yes. The tissues may have healed, but the central nervous system has become hyperreactive. The alarm system is glitching, so it's ringing loudly even when there is no fire.
And localized nerve block does not fix a systemic hypersensitized alarm system.
Precisely.
Yet over the decades, despite this evolving neuroscience, these interventional procedures became the absolute core identity of pain clinics.
They did.
And let's be super clear about the incentives here. We are talking about systemic structures, not motives.
Absolutely.
We aren't suggesting there is some malicious cabal of doctors tricking patients just to run up the billing software.
No, not at all. The persistence of these procedures is entirely driven by systemic momentum and training pathways. Just consider medical education. A medical trainee entering a pain management fellowship is driven to learn advanced technical procedural skills. Mastering the syringe and the fluoroscopy machine is literally what earns them their specialist credentials.
Right. You don't become an interventional specialist to not intervene.
Exactly. Furthermore, the healthcare system, particularly in the U.S., operates heavily on a fee-for-service reimbursement model. And that model disproportionately rewards quick, technical procedures.
Because of the volume.
Right. A practitioner can perform several injections in a single hour, generating significant revenue for the clinic or the hospital.
Whereas sitting down with a patient for an hour to, explain nervous system sensitization or guiding them through a slow, sweaty, frustrating rehabilitation program.
That pays a fraction of the cost.
Even though it requires significantly more of the provider's time and energy.
The financial architecture of healthcare heavily favors the syringe over the conversation or the exercise program. The system reimburses for what is done to the patient rather than the time spent educating or rehabilitating the patient.
And from the patient's perspective, the syringe is incredibly seductive.
Oh, absolutely.
I mean, if you are sitting there in debilitating chronic pain, you are desperate for a mechanical fix. You want a surgeon or a specialist to pop the hood, find the bad part, and swap it out.
We all want that simple fix.
Yeah. The ritual of the procedure aligns perfectly with what our culture tells us medicine should look like. So we are essentially giving patients the high-tech narrative they expect, even if the long-term data doesn't back it up.
It is a profoundly difficult truth that the medical community is currently wrestling with. We have created a healthcare culture that equates high-tech intervention with high-quality care.
And so when the clinical evidence shifts...
Right, forcing us to admit that the high-tech ritual might not be serving the patient's long-term interests. The culture shock is immense for both providers and patients.
So if we are pulling away from the syringe, what fills the vacuum? If routine injections aren't the primary answer for chronic spine pain, what do the major medical guidelines actually want a patient to do?
Well, there is an alternative.
Because you can't just hand someone a pamphlet and tell them their back pain is their own problem now.
No, and the alternative pathway is well established, even if it is currently underutilized.
What did the guidelines say?
When you look at the major guidelines from the American College of Physicians, IC in the UK, and the International Association for the Study of Pain, their recommendations are remarkably unified.
Okay, unified around what?
They prioritize active, evidence-based conservative care as the frontline defense against chronic spine pain.
Now, active conservative care sounds great in a medical journal.
But what does it mean?
Yeah, for the person waking up with a stiff, aching back every morning, we need to define what that actually looks like in practice. It sounds like a shift from having things done to you to having to do the work yourself.
That is exactly the defining shift. The guidelines strongly advocate for tailored exercise programs, multidisciplinary rehabilitation, robust patient education, and self-management strategies.
So it's about building capacity.
Yes, emphasizing building physical capacity and resilience. And crucially, they also highly recommend psychological approaches as part of a comprehensive strategy.
Okay, let's unpack the psychology aspect carefully. Because for an informed listener who has been dealing with physical back pain for years, hearing that they need therapy can sound really dismissive.
It can sound like you're saying it's all in your head.
Exactly. But framing this around nervous system sensitization changes the conversation entirely. We aren't saying the pain is in their head. We are saying the nervous system is locked in an overprotective state.
That's spot on. Pain is always a 100% real neurological output. The reason therapies like cognitive behavioral therapy or CBT and mindfulness-based stress reduction are recommended is because of how they actually alter pain processing in the brain.
How did that work?
Chronic pain is heavily exacerbated by fear of movement, stress, and how the brain interprets physical sensations. CBT helps patients reframe those threat signals.
Oh, I see.
By reducing the fear and anxiety associated with movement, we leverage neuroplasticity to literally turn down the volume on the brain's alarm system. The evidence shows these therapies genuinely reduce pain intensity and improve physical function.
That's fascinating. And alongside the active rehab and the nervous system regulation, the guidelines also recommend manual therapies.
They do, yes.
Let's talk about spinal manipulation. Because chiropractic care and osteopathy are often viewed by patients as the primary alternatives to the medical injection route. How does manipulation actually work in this evidence-based paradigm?
Manual therapy and spinal manipulation fit into this framework as one part of a broader conservative care pathway.
One part.
Yes, and it is vital to update our understanding of how these therapies work. The modern evidence-based mechanism of spinal manipulation is not about fixing alignment or, putting bones back into place to cure the root causes of pain.
Right, that mechanical model is outdated.
Very outdated.
The spine isn't a stack of loose blocks that a practitioner just taps back into a perfect vertical line. So what is the actual physical mechanism when someone gets their spine manipulated?
It acts essentially like a neurological reset button.
A reset button.
Yeah. When a practitioner performs a spinal manipulation, they are rapidly physically stretching the joint capsule and the surrounding tissues.
Okay.
This action fires off mechanoreceptors, which are sensory receptors in the joint that send a massive rush of non-painful, safe signals to the spinal cord.
So it floods the system with good signal.
Exactly. This sudden influx of sensory data can temporarily gate or drown out the chronic pain signals being sent to the brain. It also triggers local reflexes that relax muscle spasms.
So it isn't permanently fixing a structural defect, but it is providing a temporary neurophysiological effect.
Yes.
It basically creates a window of opportunity.
A window of reduced pain and improved mobility, exactly. And what a patient does with that window is what really matters.
Right, you have to use the window.
It allows the patient to comfortably engage in the active rehabilitation, the strengthening, and the exercise that actually builds long-term physical resilience.
So it's a stepping stone.
Yes. The guidelines recommend manipulation as a frontline option before moving to invasive procedures, provided it is used as a bridge to active care and not just an endless cycle of passive treatments.
Man, this entire pivot from passive to active care sounds incredibly difficult to implement on a large scale.
It is a massive undertaking.
I mean, taking a pill or lying on a table for an injection is passive, and frankly, it is easier for everyone involved.
It is.
Committing to weeks of multidisciplinary rehab, sweating through physical exercises that are uncomfortable, and doing the psychological work to retrain a sensitized nervous system that is demanding work.
It requires a fundamental shift in patient expectations and provider workflows. Which brings us to the central policy question that this BMJ data forces the healthcare system to confront.
Which is?
If the evidence clearly changes, shouldn't clinical pathways and financial reimbursement change with it?
You would think so.
We currently have a system that smoothly facilitates and financially rewards $9 billion in passive injections, while making it administratively exhausting and financially burdensome for a patient to access 12 weeks of high-quality, multidisciplinary, active conservative care.
So we are essentially subsidizing the theater of medicine while putting roadblocks in front of the actual work of rehabilitation.
Rebalancing that structural inequity is the next great hurdle for evidence-based medicine.
Which brings us directly home to you, the listener.
Yes.
Understanding the weight of a 2025 systematic review isn't just about, academic trivia. It gives you armor. When you are navigating the healthcare system with chronic spine pain, knowing this data allows you to advocate for yourself.
That's the most important takeaway.
It empowers you to recognize that jumping straight to a needle might not be the magic high-tech fix that our culture promises. It allows you to ask your doctor hard questions about comprehensive care, to seek out active physical rehab, and to avoid potentially unnecessary costs and risks.
Because knowledge is only powerful when applied to your own decisions. By understanding that chronic spine pain requires a multifaceted active approach rather than a simple mechanical fix, You can set realistic expectations.
Right.
You can actively seek out providers who are willing to do the hard, necessary work of rehabilitation alongside you, rather than those who just offer the quick, passive ritual of the syringe.
We started this deep dive talking about the clash between emerging data and entrenched medical culture. The desire for a simple mechanical fix for complex human pain is entirely understandable.
Of course it is.
But the reality is much more intricate and ultimately far more empowering once you take an active role in it. So we will leave you with a final thought to mull over.
Go for it.
We discussed how the ritual of the hospital, the x-ray screens, and the white coat feels profoundly validating when you are suffering. If the true future of chronic spine care lies in exercise, nervous system education, and active rehabilitation, how do we make active evidence-based conservative care feel just as serious, just as validating, and just as meaningful to patients as the syringe?
That is the challenge that will define the next decade of pain medicine.
Thanks for joining us on this deep dive. Catch you next time.
That's our deep dive for today. The question raised by this evidence is not whether spinal injections should disappear. It is whether their routine use for chronic spine pain still reflects the best available evidence, and whether patients have meaningful access to evidence-based conservative care before treatment escalates. If the evidence changes, our clinical pathways and reimbursement systems should be willing to change with it. You can find the studies and resources referenced in this episode in the show notes. If you found this conversation valuable, share the episode and follow the Spinal Chat Podcast for more deep dives into the research and policy shaping the future of chiropractic and conservative care. And if you are a Pennsylvania chiropractor and are not yet a PCA member, please consider joining us. PCA is the organization in Pennsylvania dedicated every day to protecting, advancing, and fighting for the future of chiropractic and your practice. Your support gives us a stronger voice and allows us to continue doing this work on behalf of the profession. This podcast is for educational purposes only and is not individual medical, legal, or billing advice. Thank you for listening to the PCA Deep Dive Series.